Good afternoon and welcome to my talk on multidisciplinary approach to pediatric brain tumor treatment, complications, and follow-up. Today, I will specifically be focusing on post-treatment complications. In the next 15 minutes, we will cover a number of surgical, radiation therapy, and chemotherapy-related complications that can be encountered on imaging in the pediatric brain tumor population. We'll begin with surgical complications, which can include postoperative pediatric cerebellar mutism syndrome, hypertrophic Olivary degeneration, stroke, aneurysm, and others such as intracranial hemorrhage and postoperative infection. We'll begin with case 1, a 12-year-old patient with postoperative mutism and ataxia. The patient initially presented with a 2-week history of sudden onset bitemporal headaches and nausea and vomiting. On an unenhanced CT of the head, you can see a posterior fossa tumor centered within the fourth ventricle. On the MRI, there is thick rim enhancement of the tumor, again demonstrated within the fourth ventricle. There is no internal hemorrhage on the susceptibility-weighted artifact sequence. This was later proven to represent an exophytic pilocytic astrocytoma. The patient was taken to the operating room or operating theater where he experienced a hypertensive crisis triggered by brainstem manipulation. He subsequently developed mutism for days to weeks, which slowly improved over time. He also had severe neck, truncal, lower, and upper limb ataxia. On the postoperative CT head, you can see extensive postoperative hemorrhage in the surgical bed. This is a case of postoperative pediatric cerebellar mutism syndrome, previously referred to as cerebellar mutism syndrome or posterior fossa syndrome. It affects up to 31% of children undergoing posterior fossa brain tumor resection. Mutism occurs 1 to 6 days following surgery and has a limited duration of 1 day to 4 months, followed by a recovery period characterized by dysarthria and long-term neurological deficits, including ataxia and cognitive disorders. Unfortunately, there are no established treatment for this condition. Our patient underwent rehabilitation, including speech, physical, and occupational therapy, in an effort to control symptoms. There are several risk factors that we can identify on imaging, which include brainstem involvement, midline tumor, medulloblastoma tumor type, the presence of hydrocephalus, and infarction and bleed. A study looking at MRI factors associated with cerebellar mutism found that postoperative perivascular infarcts and bleeds, a tumor attached to the floor of the fourth ventricle, and calcifications were more prevalent in cerebellar mutism patients. Here's a diagram of the fourth ventricle where you can see the floor and roof both delineated. Case 2 is a 15-year-old patient with medulloblastoma who presented with blurred vision, palatal tremor, and upper extremity tremor shortly following surgery. Here you can see the patient's initial baseline imaging, which demonstrates the known medulloblastoma within the posterior fossa. On the preoperative study on May 13, 2013, there is normal signal intensity involving the right inferior olivary nucleus. There are postoperative changes 3 days later on May 16, 2013. However, in December 2013, there's increasing T2 and fluid attenuated inversion recovery signal in the right inferior olivary nucleus, which demonstrates subsequent swelling and high signal intensity 2 years following surgery, with gradual decrease in swelling and persisting high T2 and flare signal up to 5 years later. This is a case of hypertrophic olivary degeneration, a neuronal degeneration condition resulting from injury to the dentato-rubral olivary pathway. Most common symptoms include cerebellar ataxia and palatal tremors. The inferior olivary nucleus typically on imaging gets larger and increases in signal intensity on T2 and flare sequences. Typically within a few months, T2 signal intensity increases and lasts for 3 to 4 years, whereas hypertrophy occurs later, at about 1 year, and resolves by 3 to 4 years. Although not typical, enhancement can occur during the early stages. The condition is usually self-limited, with treatment again focused on rehabilitation and symptom control. Our third case is that of a 2-year-old diagnosed with hypothalamic tumor who underwent craniotomy with debulking. Unfortunately, on post-op day 1, the patient experienced a 2-minute tonic-clonic movement of her left arm and right-sided weakness. Here you can see the preoperative study demonstrating the known hypothalamic tumor. The post-op day 1 CT of the head demonstrates hypoattenuation of the entire left cerebral hemisphere with an attenuated appearance of the intracranial vasculature on that side. And MRI demonstrates confirmation of a massive left MCA and ACA ischemic stroke. from vasoconstriction of the left internal carotid artery. On the subsequent images, you can see the evolution of the stroke with eventual encephalomalacia and gliosis in the affected territories. This is a case of ischemic stroke. Ischemic stroke is the most common postoperative complication. Causes can include embolic thrombotic, vasoconstriction, and iatrogenic injury to the intracranial vasculature. Case 4 is a 7-year-old with postoperative somnolence. On the postoperative day 1 non-contrast CT of the head, there's extensive subarachnoid hemorrhage with intracranial extension. There's pneumocephalus and hydrocephalus. The intracranial vasculature appears unremarkable. However, on the 5-month follow-up non-contrast CT head, there is a hypertenuating round focus at the tip of the basilar artery, which was subsequently confirmed to represent a basilar tip aneurysm. This was successfully coiled. This is a case of intracranial aneurysm. Intracranial aneurysms occurring postoperatively are not uncommon but may be occult on the initial postoperative imaging, and a high level of suspicion must therefore exist in order to assess on follow-up. We will now move on to radiation treatment-related complications. These can occur in the acute time frame from days to weeks and include acute encephalopathy, in the early delayed time frame from 1 to 6 months and include pseudoprogression, and the late delayed phase, which occurs 6 months onward and includes radiation necrosis, cerebrovascular complications, secondary neoplasms, and leukoencephalopathy. Case 5 is that of a 10-year-old with medulloblastoma who had incidental findings on follow-up. MRI from 2016, which was performed 1 year following whole brain radiation treatment, demonstrates the presence of the known medulloblastoma within the posterior fossa. However, there are also foci of blooming artifact in the left temporal lobe and in the right corona radiata. In 2018, you can see the primary malignancy within the posterior fossa demonstrating interval reduction in size. However, the 2 foci of susceptibility-weighted artifact in the left temporal lobe and right coronary radiata appear stable. This is a case of Cavernoma versus capillary telangiectasia. Radiation-based treatments may induce vascular malformations, such as radiation-induced cavernous malformations and capillary telangiectasias. These are frequently encountered within the same patient and may in fact be a part of the same pathological entity. Radiation-induced capillary telangiectasias usually occur 3 to 9 months after radiation, whereas cavernous malformations, which are low-flow vascular malformations, typically take longer to develop and occur 1 to 35 years after radiation. Case 6 is a patient with diffuse intrinsic pontine glioma, which you can see here on the baseline non-contrast CT of the head as the posterior fossa mass, causing expansion. 11 months following post-radiation therapy, you can see reduction in size of the known mass with interval development of dystrophic calcifications, which progress on subsequent imaging. This is a case of mineralizing angiopathy and calcifications. Mineralizing microangiopathy is a rare long-term complication in children, present in 28% of survivors. It represents the deposition of calcium in small vessels secondary to fibrinoid necrosis. The most prevalent symptoms are headache, convulsions, and slurred speech, although some patients are asymptomatic. On imaging, it presents as dystrophic calcifications located at the basal ganglia, cortico-subcortical junction, and cerebellum. When located at the basal ganglia, it may increase the risk of stroke after minor trauma due to affecting the lenticulostriate arteries. No firm recommendations are available at the moment regarding the management of these patients. However, preventative care is recommended to minimize reversible stroke factors. Case 7 is a 16-year-old patient with craniopharyngioma who presented 4 years following surgery and radiation. You can see on the initial imaging from 2015 a mixed solid and cystic mass in the suprasellar and sellar region consistent with craniopharyngioma. On the follow-up imaging in 2019, there are extensive post-surgical and post-treatment related changes within the suprasellar region consistent with treated craniopharyngioma. This was the patient's baseline MRA in 2015, where you can appreciate a normal and symmetric right anterior cerebral artery and middle cerebral artery. 4 years later, after multiple debulking surgeries and radiation therapy, There's focal narrowing of the intracranial proximal segments of the right anterior cerebral circulation, including the supraclinoid internal carotid artery, right middle cerebral artery, and severe stenosis near occlusion of the right anterior cerebral artery. You can see these changes better here as well. This is a case of radiation-induced arteriopathy, which can be steno-occlusive or moya-moya-like vasculopathy. Pediatric cancer survivors treated with radiation treatment are at substantial risk for late occurring strokes, occurring approximately 12-fold between 10 to 30 years post-diagnosis. The risk is radiation dose dependent and increases with age. Case 8 is a patient with medulloblastoma with possible recurrence on follow-up imaging. You can see on the initial imaging in 2009 that the patient presented with a posterior fossa mass, which enhances post-contrast and is avidly restricting diffusion, typical for a medulloblastoma. No evidence of spinal metastases were identified at the time. 10 years later, on the follow-up MRI in 2019, we see postoperative changes but no recurrent or residual disease. However, in August 2020, we see a broad-based homogeneously enhancing nodule in the region of the torcula. This marginally increases in size in the span of a month. This was resected and was found to represent grade 1 meningioma. Case 8 is one of radiation-induced secondary neoplasm. Most radiation-related cancers are diagnosed only after decades of radiation exposure, and the risk further increases by time. As children and young adults are likely to survive for longer duration after anti-cancer therapy, they are at the greater risk of developing radiation-induced secondary malignancies, which typically include meningiomas and gliomas. Case 9 is a 4-year-old patient with diffuse midline glioma who presented 4 months following whole brain radiation treatment. On the baseline study, you can see the diffuse midline glioma presenting as expansile high flare signal abnormality within the brainstem. However, supratentorally, there's no signal abnormality. On the MRI, 4 months of post-whole brain radiation treatment, there is reduction in size of the abnormal signal within the brainstem. However, there is now symmetric diffuse white matter hyperintensity and atrophy in the supratentorial brain. Case 9 is one of radiation-induced leukoencephalopathy, which is thought to be due to damage to oligodendrocytes, which causes axonal demyelination, coagulative necrosis, vessel thickening, and focal mineralization. Radiation-induced leukoencephalopathy may be subclinical, at least initially, although it can result in cognitive deficits later. On imaging, it typically presents as high T2-weighted or fluid-attenuated inversion recovery signal within the cerebral white matter, usually without enhancement or significant mass effect. It typically exhibits diffuse and symmetric involvement after whole brain radiation treatment, with relative sparing of the subcortical U fibers, corpus callosum, and gray matter. White matter lesions usually develop around the periventricular white matter at the beginning and progress to diffuse white matter changes with varying degrees of cerebral atrophy over months or years. Lastly, we will talk about chemotherapy-related complications, which typically occur as a direct toxicity to various structures in the central nervous system. There are many leukotoxic agents, with the most common being methotrexate. There are also extracranial complications that can occur as a result of chemotherapy. However, we will not be covering these today. Case 10A is a 3-year-old patient with acute myelocytic leukemia who presented in status epilepticus 2 days following intrathecal high dose of methotrexate. On MRI, you can see multiple patchy foci of white matter, flare, hypertense signal, for example, within the centrum semivalley. None of these areas, however, demonstrate restricted diffusion. On the follow-up MRI 1 month later, these flare lesions are slightly brighter and more conspicuous, easier to delineate. Otherwise, there is still no significant change. These findings are nonspecific, and the differential can include posterior reversible encephalopathy syndrome, methotrexate-induced leukoencephalopathy, and inflammatory disease such as acute disseminated encephalomyelitis. Case 10B is an 11-year-old patient with a history of acute lymphocytic leukemia and new onset seizure 1 week following intrathecal methotrexate. On the non-contrast CT scan of the head, you can see diffuse hypotenuation in the cerebral white matter. There is maybe mild hypotenuation in the same areas on non-contrast T1, no abnormal enhancement following contrast administration, and there's more or less symmetric mild flare changes. No internal hemorrhage. However, there's significant abnormality or high signal on DWI with corresponding EDC hypointensity. The differential considerations here also include, of course, central nervous system infection or leukemia. However, both of these cases represent methotrexate-induced leukoencephalopathy. Direct toxic effects on the oligodendrocytes and vascular injury have been proposed as the likely mechanisms of methotrexate-related neurotoxic effects. There's often rapid deterioration of neurological symptoms after treatment, with presenting symptoms being personality change, confusion, ataxia, seizures, and coma. On imaging, there's typically diffuse, usually symmetric low attenuation in the cerebral white matter, although asymmetric involvement has been reported. Mass effect is uncommon. So today we covered a range of surgical, radiation therapy-related, and chemotherapy-related complications following treatment for pediatric brain tumors. Thank you for your attention. Дякую за ваш час і за вашу увагу.